So it is my pleasure to introduce our last speaker for the year, Dr. Kovacic, with our division of cardiology. He's one of our interventional cardiologists and associate professor here. And he's here today to talk about fibroblast dysplasia, something that's been studied in a pretty large trial that is going quickly to be published in the Genomic journal. And tell us more about that. So thank you very much for the question.
Thank you. Thanks everyone for having me. It's Andrew for inviting me. It's a great pleasure. I know I think about half the faces are in the room, and it's a pleasure to connect a bit more with you. So it's a sort of scary title even for me, and I'm going to break it down and step you through it. I think it's a really timely talk. Fibromuscular dysplasia is a disease that's very much underappreciated, underrecognized, and underdiagnosed. And it's far more common than we appreciate. And this multi-omics thing, I think, is definitely a tool and a methodology you're going to be hearing more and more about in the coming years. So these are learning objectives, really just to make you a little bit more aware of fibromuscular dysplasia, and also this thing about machine learning and multi-omics and what all that stuff's about. And I want to say from the get-go, I present this talk on behalf of our whole team. There's a huge group of us. There's about 20 involved in this research project, and it's been a lot of effort from a lot of people over the last 5 years. And I just highlight to you one person here, which is Pam Mace. She's a blonde. I've already lost the pointer. She's a blonde. She's a blonde lady here. Pam has fibromuscular dysplasia. This lady here, she's had, I think, 3 strokes, a heart attack. She's got kidney failure, and she's the founder and CEO of Fibromuscular Dysplasia Society of America. She's just a wonderful force, and she's been highly supportive of us and this whole initiative. So, on behalf of everyone, before we dive into the disease, I thought I'd just go and tell you about what I mean by omics. This is a word you've probably heard bandied around, thrown around for the last couple of years. It's really this generic term that encompasses anything that ends in this sort of snippet omics. So there's sort of different groups of biological data, usually quite complicated, usually with thousands to tens of thousands, even hundreds of thousands of pieces of data per group. So this includes transcriptomics, and a transcript is just a gene. So it's really looking at gene expression levels, and that could be mRNA, microRNA, different forms of RNA. Proteomics, which is just the study of proteins, and in fact that's what I'll be talking a lot about today. Lipidomics, the study of lipids. Metabolomics, the study of metabolic intermediates like leptin, adiponectin, just to name a couple, glucagon. Epigenomics, which is DNA changes that make it easier or harder for DNA to be transcribed, like methylation is the classic one. And there are other forms of omics that are coming on the horizon. So this is really what's meant by omics. It encompasses all of these things. So really, to break the title of my talk down, what I'm really trying to say in this title is, can we use different types of high-level complex data from different disease-relevant tissues like blood and cells to identify what's going on with fibromuscular dysplasia by its different molecular features? And really, can we learn about fibromuscular dysplasia from this molecular signature? So, I want to start with a case, and this is a true case. So it's only about a year ago, it wasn't that long ago. I was in call for the cath lab. 66-year-old female came to RER with chest pain that began that morning. She was from the Dominican Republic, right-sided, a little atypical, some nausea, vomiting, also felt dizzy and had some headache. Classic sort of atypical features for a woman having an acute coronary syndrome. She had some sort of heart attack in the DR several years before. She said she hadn't had a PCI or stenting or anything, and her only medication was aspirin, no allergies, and she was a non-smoker. So she was quite thin, vital signs were fairly normal, a little bit bradycardic, blood pressure normal, really fairly unremarkable examination. Her first EKG is actually fairly unremarkable, and you see the ST segments are fairly isoelectric, sinus rhythm, not a lot going on in this EKG. Chest X-ray was actually clear, no pneumothorax or other problems. White cell count was up a little bit, which can be a sign of go with an acute coronary syndrome at least. And troponin came back at 0.96, so this is up slight but definitely elevated. And then an EKG started evolving this lateral T-wave inversion, and I think that combined with a positive troponin was enough to make it fairly clear she was having some form of acute coronary syndrome, although being female, she was having atypical symptoms of right-sided chest pain and troponin. So she was brought up to the cafe. So this is the angiogram, and immediately the thing that strikes me, so just to show you through this, the heart's in here, the arteries are wrapping around the outside. This is our catheter coming up from the groin, goes around the arch, the aortic catheter sitting in the mouth of the left main coronary artery. This is the circumflex coronary artery coming down here. This is the left anterior descending artery going away from us in this projection. Immediately strikes that this is quite a tortuous vessel, and even the LAD here is quite tortuous. Here again, left main, circumflex coming down here with this big couple of bends. Circumflex down here is the obtuse marginal branch. The LAD runs across here, quite tortuous in here, and then comes down the front of the heart. And if I can pause it just here. Let me see if I can do this. Yeah. What you notice about this LAD is it comes down, it's quite a big caliber vessel, and suddenly it just tapers down to a very small vessel, and it continues down in this very small caliber all the way to the apex. And if anything, it actually gets slightly bigger here right at the apex. So this long, thin, diffuse narrowing of the LAD. This is a cranial projection, the same thing. This is the LAD coming down here, and you can see again this long, thin, diffuse narrowing to the ascending coronary artery. Here it is shown in still for you, the LAD here, this long, thin, diffuse narrowing. So this is a classic appearance, and this is something we've only appreciated in the last 5 years of a tracking intramural hematoma. So you've heard of coronary dissection, and you think of these big flaps of tissue in the LAD, and the vessel's obviously torn. This is a form of spontaneous coronary dissection. It's actually quite common. Previously, until 5 years ago, we used to. Some very elegant studies that came out of Canada showed that this is not diffuse spasm. This is actually dissection which starts up here, and the dissection flap propagates down the vessel, and you get blood just tracking down the vessel, giving this diffuse narrowed appearance. So we now know this is a classic appearance of an intramural hematoma, which is a type of spontaneous coronary artery dissection. So indeed, this was her diagnosis of spontaneous coronary artery dissection. Right coronary artery, very tortuous, but otherwise normal. No dissection, not a problem. So, what's this? This is a DSA angiogram, digital subtraction angiography of the left kidney. Why did I do this? Because I knew that associated with spontaneous coronary artery dissection is fibromuscular dysplasia. And if I just show you a still here, you can see the classic beaded appearance of this left renal artery. So she had classic features of fibromuscular dysplasia. This is a classic drive-by angiography, but I think in this case we're not fishing around for RVUs to put stents into renal arteries if people don't need them. It's actually a very sensitive diagnostic test for fibromuscular dysplasia. DSA of the right renal, you can see it's actually quite narrow in caliber, and again there's this string of beads appearance here. So she had actually bilateral fibromuscular dysplasia as well as spontaneous coronary artery dissection of the LAD. So how do we manage this? We know that intervention on this has a very, very high complication rate because of difficulties of getting into the true lumen and milking of this hematoma up and down the artery. So we try to avoid any interventions for patients who are at all stable. She just managed medically on aspirin and Plavix, some ARB. We withhold statins in this because this is not an atherosclerotic process. We only give them statins if they have an abnormal lipid profile, and hers was normal. Given some beta blocker initially, but we ended up being stopped because she was bratty, and went home a couple of days later. We also did a CT angiogram of her head and neck. The reason is, with fibromuscular dysplasia, one of the complications can be intracerebral aneurysm, which can be fatal if the aneurysm ruptures. So she had a CTA of the head, and it actually showed this incredibly tortuous left internal carotid artery here. This is what's called an S-bend, and the S-bend is another one of the classic features of fibromuscular dysplasia. Ramesh, you're welcome to join. So this lady had the full hand of fibromuscular dysplasia. Thankfully, no intracerebral aneurysm. So what is this fibromuscular dysplasia disease before we get into this multi-omics business? This is a classic appearance. You've heard about this string of beads before, but this is a classic string of beads appearance of the renal artery. Here you can see it in the carotid artery. It's a disease that was first described almost 100 years ago now in 1938. It's a non-inflammatory vascular disease characterized by vascular fibroblast proliferation and collagen deposition. You can see here this pathology with this diffuse collagen deposition throughout the wall of the vessel. And what this does is it leads to strictures and these fibrous tissue bands that give that classic string of beads appearance here, you can see here. So this is all collagen and vascular fibrosis causing this narrowing. You can see here different manifestations. You can have a string of beads. I don't know if you can see that behind the snowstorm there. You can also have focal stenosis, dissection here of this carotid, aneurysm formation here, as I've already mentioned, and this S-bend tortuosity. So multiple different manifestations of fibromuscular dysplasia. And obviously this is just the carotid arteries. This disease can affect any medium or large sized vessel in the body, including the coronary arteries. How do we classify it? In the 70s, there was a histopathological classification system that's now not used because we rarely operate on these patients anymore, so we rarely get tissue on them. So now it's an angiographic classification system of focal fibromuscular dysplasia or multifocal fibromuscular dysplasia. And these different forms approximately correlate to some of the histopathologic forms that were described in the 70s. So this is where it gets really interesting. What do we know about the demographics, clinical features? Overwhelmingly, this is a disease of women. It's about 10 to 20 to 1, women versus males, depending on which series you read. The mean age at diagnosis is in the mid-50s, and the mean delay to diagnosis is about 5 years. And this is because of the very difficult symptoms that this disease presents with. Obviously, when they present with acute coronary syndrome and coronary dissection, it's a little easier. But the symptoms are typically far more subtle. Headaches, neck pain, pulsatile tinnitus, that's a whooshing sound in the ears, TIA and stroke. Obviously, headaches, neck pain and tinnitus could go for years being undiagnosed. Hypertension is another common manifestation. In the iliac's claudication, coronaries, myocardial infarction and chest pain. These are some of the common manifestations. I can say that other subtle manifestations like arm claudication with arm involvement, or it can be sudden death if it's a large stroke, large EMI, or one of the fatal ones is gut ischemia as well if the mesenteric arteries are involved. Interesting, at the time of diagnosis, there are a lot of these more sinister vascular features, including aneurysm, dissection, which infects about a half of patients, aneurysm or dissection. No aneurysms or dissection, just a string of beads, in about another half of the patients. And the common locations of dissection are the carotids and renals. So then to link fibromuscular dysplasia back to spontaneous coronary artery dissection. So this was a study again out of Canada looking at spontaneous coronary artery dissection that involved 50 patients at Vancouver General Hospital. These patients with spontaneous coronary artery dissection, mean age very, very similar to the mean age at diagnosis of fibromuscular dysplasia. Again, overwhelmingly female, just like fibromuscular dysplasia. Most had non-STEMIs, just like the lady I showed you. Very uncommonly postpartum. You know that there's association between the postpartum state and spontaneous coronary artery dissection. That's probably been overplayed, and it's probably just a minority, 2 to 5% of spontaneous dissections that are postpartum. About 10 to 12% had more than one dissected vessel. And importantly, if they looked for fibromuscular dysplasia, they found fibromuscular dysplasia in about 86% of patients in this study, of patients with spontaneous coronary artery dissection. So a strikingly high overlap between these two diseases. Other studies have given numbers that are not quite that high, that the overlap is not that as close, maybe in the order of 50 to 60%, but nevertheless there's a striking association between spontaneous coronary artery dissection and fibromuscular dysplasia. And indeed myself and quite a number of others in our investigative group around the world are starting to believe that may in fact be exactly the same disease, just with different manifestations. These are the ways that a coronary artery dissection we now understand can manifest. This, until 5 years ago, this is really all we understood, all we knew about, all we recognised was when you had obvious flaps of tissue in the coronary vessels. Now we know that spontaneous coronary dissection can have this smooth distal narrowing. It can also have intramural hematoma, which is a form of this, but this is more involving more proximal vessels, and this dramatic tortuosity of the vessels as well. And here's another example of this smooth distal tapering and narrowing that I've shown you already, which we now appreciate is a form of spontaneous dissection. So to move a little bit to fibromuscular dysplasia and what we're starting to understand now about this disease through our research studies. So it's known from the 70s that fibromuscular dysplasia, when they were getting tissue samples from these patients, likely involves some derangement of fibroblast cells. This is from when you actually could see normal myofibroblasts here. This is the basement membrane myofibroblast here, smooth muscle cell here, and you can see a myofibroblast here in a patient with fibromuscular dysplasia, grossly deranged, convoluted nuclear contour, secretory organelles, very different to the fibroblasts in healthy control. And we really knew that the landscape was changing with fibromuscular dysplasia because what had happened was some very elegant studies were done in renal transplant patients, and particularly the donors for renal transplantation. And people went back and started looking at these pre-donation angiograms, renal angiograms, when they were available, and also at the tissue of these renal arteries when they're going in for transplant. And retrospectively, we appreciated that up to 5% of supposedly healthy female renal kidney donors probably had undiagnosed fibromuscular dysplasia. And there was then another study that came out of this CORAL study. CORAL was a study of renal artery stenting. And fibromuscular dysplasia was an exclusion criteria for this renal artery stenting study. When a different group came in and retrospectively reanalyzed all the angiograms from this renal artery stenting study, they found that, again, about 5% of patients had undiagnosed fibromuscular dysplasia that had been misdiagnosed as an atherosclerotic renal artery stenosis and actually underwent stent. So it's probably grossly underdiagnosed, although the clinical manifestations, as I said, can be very difficult, and probably a lot of patients actually don't have any manifestations at all. They've just got mild diffuse narrowing of a few arteries that may never present. But all the data suggests this is a much more common disease, potentially affecting up to 1 in 20 females. A genetic component is very likely because about a third, up to a third, appear to show some familial pattern of appearance, but the cause of this is really entirely unknown. And what I've shown you to this point is really all we knew about the cause of fibromuscular dysplasia up to 5 years ago. So we started studying this disease in about 2011, 2012, and so far we got involved in this international consortium that pulled all of our data on fibromuscular dysplasia. And this isn't going to be one of the feature things I'll be talking about today, but I did want to cover it, that we've now found one gene, so we've found a couple now, but we've this time found this one gene, PRACTA1, that's associated with fibromuscular dysplasia. And what's fascinating about this took a pooled analysis. Nabila works in Paris, Ifakar is at Mayo, Santhi Ganesh is at in Michigan, ourselves here at Sinai. This was an international group, about 5 different data sets, and we just scraped up around 500 cases of fibromuscular dysplasia to find this one gene. You may have seen this as called a Manhattan plot. Obviously looks like a Manhattan skyline. This is the line for statistical significance, and you just see we got this one gene that with a little statistical push made it over the line. It's called PRACTA1. What do we know about it? We know it's highly expressed in the vascular wall, as you might expect. And we know, you can't really appreciate this, but this is showing that it's involved in cellular architecture and the stress fibers in smooth muscle cells. Can I get you to turn the light off at the back? Maybe it'll help a bit. It's a single gene associated with this. Right? Great, that's cool. So you can see these stress fibers here. If you knock out PRACTA1, you can see a dramatically reduced stress fibers. We also found there's an association between the gene, I won't get into this, but the gene, the DNA gene, the SNP single nucleotide polymorphism appears to affect expression levels of PRACTA1. That's all we knew. What was fascinating about this, and just to go back to the heading, what was fascinating about this PRACTA1, without getting into the biology of this, but PRACTA1 is a gene the same exact gene has already been implicated in migraine headache and cervical artery dissection. As you know, we've already said cervical artery dissection is one of the phenotypes of fibromuscular dysplasia, suggesting that this may be a diffuse vasculopathy. We also have now a paper that's accepted for publication showing this precise same gene is also implicated in spontaneous coronary artery dissection. However, this gene has a very weak effect in causing the disease and is also interestingly involved in coronary artery disease and standard atherosclerosis. But it's a weak causal driver of the disease process of any of these disease processes. But what it has done, it has immediately pointed the direction of the genetic basis of this disease, because this is what's called a common polymorphism or a common single nucleotide polymorphism. These common genes are involved in common disorders like atherosclerosis, hypertension, and it puts this disorder, fibromuscular dysplasia, and cervical artery dissection, and spontaneous coronary artery dissection into this bucket of common disorders, just exactly the same as hypertension, diabetes, height, weight, all of these things. So it potentially is not some autosomal dominant or autosomal recessive disease, but more likely to be a complex disorder, the same as a lot of the other diseases we deal with on a daily basis. So I wanted to spend some time now bringing you up to speed on what we've been doing and getting back to what the title of the talk was, is omics profiling and looking into the disease. So we just started this study to find FMD. We notified clinicaltrials.gov about 5 years ago, but we actually started this about 2 years prior to that. So we've been going for about 7 years now with this study. We're running it. We're hopefully going to get funding soon, but until this point, it's been entirely funded by philanthropy. Run through the clinics of Jeff Olin and Daniela Cady and Donov. I'm sure you know these people. They're wonderful vascular physicians here at Sinai. We were initially targeting 200 patients. We enrolled 200 and thought this was such a great and powerful design. We had to go to 400. We're almost at 400 now. We've already appreciated we want to go to 600. So, as I said, we've been going for about 7 years. So what are we doing in this study? We're enrolling patients with only multifocal fibromuscular dysplasia, documented by imaging, and all patients are also entered into this US registry of fibromuscular dysplasia. And we're also enrolling healthy controls, and we're being very rigorous with the enrollment of the controls. They're all matched by gender, so again, they're 95% female. They're all matched by race or ethnicity, age, smoking status, body mass index, and number of blood pressure medications. And I say this all the time, but to show you my passion about this study, both my wife and my mum can healthy controls in the study. So as I said, we're only enrolling the multifocal form. This is about 80% of fibromuscular dysplasia. The unifocal form affects about 20%. So we're not enrolling these because we wanted to minimise the genetic variance. And if this is a subtly different disease, there may be different genes involved. We wanted to narrow our focus on the most common form of disease. So the backbone of this study is actually studying fibroblast cells. And we know that we can obtain fibroblast cells by doing a 2 millimeter punch biopsy. I'm sure you've all in this room done them at some stage during your training, or if you're not still doing them now. This is just a standard dermal biopsy instrument, 2 millimeters across. We get these tiny bits of tissue, 2 millimeters. We can then take them back to the lab, plate them out on a cell culture dish. And what you see here is this is a piece of the dermis. About 4 weeks later, these are all fibroblast cells. You can see there's probably 500 to 1,000 fibroblast cells growing out on this culture dish, which arise over a couple of weeks. We're able to harvest these fibroblasts, extract the RNA, and then do RNA sequencing to quantitate the expression levels of up to about 100,000 genes in these cells. In addition to the fibroblasts and looking at the fibroblast gene expression, we can also look at the migration, proliferation, and other phenotypic features of these cells. We're also getting blood, and from that we can get plasma, and from that we can look at protein and RNA levels, and this is proteomics, a part of the study. We can also get leukocytes and look at DNA. We're indeed doing this as well. And we're then integrating the whole thing through a system genetics approach. This is Valentina in my lab, another of the team. This is a tissue culture incubator. This is like the size of a mini bar fridge that keeps these tissue plates at 37 degrees at body temperature. These are all plates, racks of cells from different cases and controls in the study. So we've now enrolled almost 400 subjects, almost half cases, half control, recruiting 1 or 2 people a week. And Valentina almost exclusively handles all the cells in the study. So I wanted to then show you what we've been working on, and I think the cool and interesting data we've found. This is the title of a paper now under it's. I mean, I hesitate to say this because you know how it is with journal submissions. You go from one day elated, the next day you're totally rejected, but it's currently under review at New England Journal. Whether it gets in there, I've got no idea. But a plasma proteogenomic and lipid signature of FMD. So what we did about 2 years ago now, or a year and a half ago, was to we cherry-picked the cleanest subjects in the study and matched them up with controls. So as I said, we have about 160 controls, but there's a smattering of some African Americans, there's a few Asians, you know, they obviously have different genetic backgrounds. So we really channeled this study down to purely Caucasians to minimize the genetic background noise. Throughout all the sort of cousins and brothers and sisters, because at this stage we already knew this was likely a complex disorder, so we didn't want to bias it. Got the cleanest 90 subjects we had, matched them up with 100 controls. Then we did this high throughput plasma protein profiling. This is a platform that has actually come from Europe, where they're able to measure about 1,000 different proteins in plasma. And then we looked at the DNA and did what's called SNP-based genotyping. So this is not technically DNA sequencing. This is looking at all the sites where there are common polymorphisms, like that practor gene I was talking about before. There are about 1 million of those known and identified single nucleotide polymorphisms across our genome. And this way of looking at the genome just tells us what the readout is of those 1,000 known sites for polymorphisms. So these are the characteristics of the study. We took exclusively females. We threw out all the males because, again, we wanted to minimize the background noise in the study. Age at diagnosis was spot on for the fibromuscular dysplasia group. As we've said, this is the mean age of diagnosis. Age at study enrollment, about 3-year lapse between diagnosis and enrollment. And matching cases to controls, very close matching across all these body morphology characteristics. One challenge we had in the study, and I'll come to this in a moment, is that the FMD subjects are obviously using a bunch of medications, not surprisingly, ACE inhibitors and ARBs. Almost all of them are on aspirin. A lot of them were on beta blockers and also on statins. And of course, the controls, as you'd expect, were on very low numbers of these medications. And this is something we had to account for in the study. Looking at the FMD vascular features of these women, about 1/3 had aneurysm, about 1/3 had a dissection, about 15% had a prior stroke or TIA, 70%, 77% had cervical artery or vertebral artery involvement, just a smattering had coronary artery involvement, and this perhaps reflects that we've only become a lot more savvy about coronary artery involvement in the last few years. Mesenteric involvement in about 15%, renal, as you'd expect, in 75%. Total number of arterial beds involved, the median number was 2 in the study. So really pretty classical FMD patients, perhaps reflecting with 2 arterial beds involved, a lot of symptoms, a little bit of a referral bias. That these are the patients obviously that have symptoms or have events that have come to our clinic and that have ended up in the study. So this was what floored me completely. I'll never forget when I saw this for the first time. So we measured 1,000 proteins, as I said, in these 90 cases and these 100 controls. This is called a Volcano Clock, and what you see here are 1,000 proteins. This, to this side, represents proteins that are increased in fibromuscular dysplasia. To this side, represents proteins that are increased in the controls. And the blue line here represents statistical significance. So anything above the blue line is statistically significant. So you can see we actually found a significant number of proteins that showed differential expression between FMD patients and the controls. And this is after full statistical adjustment for multiple comparison tests, a Bonferroni correction. Notably, there was a few standout proteins. I was delighted that in fibromuscular dysplasia, the top hit was fibroblast growth factor 19, a fibroblast-related protein. Interestingly, glucagon also comes up as one of the top differentially expressed proteins. And indeed, these 2 proteins lie the furthest out from unity. So these 2 proteins had the largest fold change compared to the FMD subjects. So these are actually increased in the controls or decreased in the FMD patients. And I'll just highlight one other here. CD2AP sits in here, and I'll come back to CD2AP in a minute. So what was fascinating about this, once I sort of calmed down, because of course we might have found nothing whatsoever at this point. There may have been no differences in the plasma proteins. We found this rich difference of 100 proteins. The next thing we had to do was convince ourselves, and particularly me, that this wasn't driven by medication use, because as I've told you, as you'd expect, the FMD patients take a whole bunch of medications that the controls are not. So this is called a heat map, and basically the stronger the colouring, the greater the difference in the level of expression. So what you've got here are all the 100 proteins, 105 proteins in the horizontal rows. In this column is the fibromuscular disease status, so whether they have the disease or not. And these are the 105 proteins associated with the disease signature. So as you expect, these yes, no, do I have the disease or am I in control? Their status is strongly associated with these 105 proteins, as you'd expect, because these are the 105 signature proteins. These are medications. It's off the bottom of the thing here, but this is aspirin use, beta blocker use, ACE, ARB, or statin use here. And you can see that the use of these medications is extremely weakly associated with any of these proteins. And in fact, none of these reach statistical significance, whereas all of these are statistically significant, indicating that medication use is not at all driving this protein signature we see in this disease. And indeed, we actually conducted several other analyses. We built a regression model, throwing medication use and not use into this model, and medication use had nothing to do with any of these 105 signature proteins. Interestingly, in fact, supporting all of this was high quality work. We did look at ACE inhibitor use. ACE inhibitor use was associated with renin levels. Not surprising, but renin wasn't actually one of the signature proteins associated with the disease. And similarly, I think statin use was associated with a couple of proteins that were not associated with the disease signature. So medication use does not appear to have anything to do with this protein signature. So our next thing we did was look more closely at these proteins, and this I found fascinating. This is just linking these 105 proteins to plasma lipid levels or metabolic function. It really hit me in the eye after looking at these data for a while that these proteins were heavily enriched in proteins known to regulate lipid levels, including the top two hits, glucagon and FGF19 that I was talking about before. These are known to regulate lipid levels. And I think that LPL, lipoprotein lipase, you're aware of, LPL was also one of the signature proteins. So lipid levels were not measured in this protein platform that we used. So we actually took all the samples and sent them back out to have lipid levels reanalyzed. And this is what we found. Again, a volcano plot. We measured 31 different lipid parameters. FMD here showing that we had an increase in unsaturated fatty acids in the FMD patients. And in the controls, we had an increase in basically a whole bunch of different triglyceride moieties, HDL triglycerides, LDL triglycerides. This is basically triglycerides carried by the LDL particle, saturated fatty acids, serum triglycerides. So we actually found this signature included differential expression of lipids in FMD patients. Never before reported, although there is one study in cervical artery dissection that suggests there may be lipid changes in that study, but not as rigorously done as in our study. So I was, again, so floored by these data, and we've been intending to do this as a quick chip shot study and get it out and publish it quickly, but we realized the data was so profound that it was not doing it justice just to send it out and publish it quickly. We decided we had to validate it. So we then didn't have enough subjects. This delayed us about a year, but we got up another 23 cases and 28 matched controls, totally independent to the initial cohort, and set out to validate. And you've seen these data before, but what I'm highlighting here is that everything with a blue ring around it was a protein that was subsequently validated with this independent validation cohort. So our top hits were validated, and generally most things that show were at the higher ends of differential expression were successfully validated. These are the successfully validated proteins. We ended up validating 37 proteins in this FMD protein signature and 11 lipids in this lipid signature. Interestingly, lipids tend to be favourably altered in FMD patients, so they have reduced triglycerides, reduced saturated fatty acids, and slightly the only lipid that's increased, which is off the scale used, is increased unsaturated fatty acids. A lot of proteins were increased in the FMD cases, but a couple were decreased. And again, I draw your attention to this CD2AP, one of the validated proteins that I'll be talking about a little more in just a second. We then just cross-correlated lipids against proteins because one of the motivations for doing this lipid study was because some of these proteins are known to govern lipid levels. And lo and behold, there were some associations that jumped out, exactly the same associations that we'd already described to exist. And indeed, FGF19, our top protein, and glucagon, our second top protein, both richly associated with different lipid expression levels, as has already been described. So we essentially validated that there may be some causality between these altered proteins and secondarily altered lipid levels. So the next question, could any of these proteins actually be causing the disease? And this gets a little basic sciencey, so I won't go too deeply into this. But what we did is we looked for, are any of these 37 signature proteins associated with any DNA loci that could be potentially controlling their levels of expression. We found that of the 37 validated proteins, 5 proteins appeared to have some DNA hierarchical control of their levels in protein plasma. We then went back to our original international consortium where we found that one gene and asked them to look up these 5 different DNA loci to see if we could actually validate any of these 5. And by now they had 500 FMD cases with 876 controls, totally independent of us. This is enough. This is like a third data set we brought in addition to our validation and discovery cohorts. And we successfully validated that this CD2AP that I've shown you before was indeed associated with loci upstream of this gene encoding region at a fairly high level of fairly high statistical significance. The best association had a p-value of 0.003. So we effectively found the second gene ever associated with fibromuscular dysplasia. This is what's called a locus zoom plot, but basically you can see CD2AP here. These are all the different DNA loci associated with CD2AP. And here you can see basically a spike here. This is the p-value, a spike in these loci associated with the CD2AP, proving the association with fibromuscular dysplasia. So, I won't go into this in great detail, but obviously the next thing is, well, where's the protein expressed? Where does it come from? This is renal artery, internal mammary artery, and aorta. This is from separate human samples with all acquired here at Sinai. CD2AP staining is shown in red. This is the lumen of the vessel. Green is the endothelium, and you can see that basically there's robust expression of this CD2AP protein by the endothelium, and we now believe that the endothelium leaks the CD2AP protein, which we're then able to detect. But critically, the renal artery, which is one of the signature arteries of involvement of this disease, shows robust expression of this CD2AP protein. So what is the evidence for a causal role of this CD2AP in FMD? Firstly, we see increased abundance of the protein in plasma in cases versus controls. CD2AP is only one of 5 proteins that show genetic control. We did this Bayesian analysis. I didn't go into this, but it suggested that CD2AP is actually upstream and causal. We validated the association in an independent data set. We showed expression of CD2AP in the endothelium of these arteries, and it's an interesting causal candidate. Basically, CD2AP has already been shown to be associated with Alzheimer's disease, and the mechanism of association is through perturbation of cell-cell adhesion with affecting the blood-brain barrier, with secondary protein deposition in the brain being the mechanism affecting Alzheimer's. So it's known to have some vascular association already. So it's a perfect candidate. So we now have actually acquired mice with knockout of CD2AP, and we're starting to study them in the context of FMD. Much more clinically relevant now. Changing gears. We've got this signature of proteins and lipids that we've validated. Can this signature be used as a diagnostic test for FMD? You know that the only way to diagnose FMD is with angiography, and it's usually either catheter-based or CT angiography. So there's a high dose of radiation currently associated with diagnosing this disease. So, sorry, I didn't change the heading here, but this is sort of rationale for a test. The only way to make a diagnosis is CTA. So we did this machine learning. What's machine learning? Machine learning is when you throw this signature at the computer and ask the computer to model and remodel using this data predictive algorithms for the disease. The computer takes about 2 days. This is Minerva, the supercomputer here. We have to actually buy processing time on Minerva. It takes it about 2 days, but it plugs in all possible permutations of these signature proteins, asking can it calculate, can it generate a mathematical equation to predict the likelihood of fibromuscular dysplasia. And what we did with this study was we used our discovery cohort, the initial 90 cases and 100 controls, to build the algorithm, and then we used our validation cohort to independently test how the accuracy of this algorithm for diagnosing FMD. So an initial model with just proteins only had an area under the ROC curve of 0.61, and you'll be familiar with this, and I'll show you in a second. When we added lipids, we got an area under the ROC curve of 0.73. So you've seen these before. This is called a receiver operating characteristic curve. Basically, lines that go up in this direction are highly predictive. This is the line of unity, so there's no predictive capacity whatsoever when things are on this line. So you can basically see using proteins only, we have modest predictive capacity. Using proteins plus lipids, we're starting to get to reasonable predictive ability of fibromuscular dysplasia. And bear in mind that this is independently applying our test to the validation cohort. So these are the numbers you're sort of familiar with. This you've all seen, and I laughed myself silly when how many times have we learned this for different exams and things in our lives? We thought we'll never ever use this, A, B, C, D, sensitivity equals A plus C divided by D. I can't even, but there I was using this silly stuff that I thought I'd never have any use for at all. Sensitivity is about 80%, and negative predictive value is about 80%. Bear in mind, this is a preliminary version of the test. It's just a pilot study, but showing, I think, quite reasonable specificity, a sensitivity and negative predictive value for this early test. Could we do better? Because obviously that's not ideal for clinical tests. Well, we've got this fibroblast data, and this is now transcriptomics. This is a volcano plot for differential gene expression from fibroblasts, and you can see here a whole bunch of differentially expressed genes in cases versus controls from the fibroblasts. So just as we have a plasma protein and lipid signature, we have a gene expression signature in these cells. This is the receiver operating characteristic curve for predicting fibromuscular dysplasia from skin cells. And the area under the ROC curve is actually 0.87. It's actually much better than the plasma proteins. Not surprising because, as you know, the blood is prone to all these variable aspects such as your hydration status, your time of day for females, the time of month, hormonal status, fasting, not fasting, and so on. These cell data, and these cells have been grown in culture for 6 weeks, are sort of stripped bare of all those factors of variability, so that the cells actually appear to be highly predictive of FMD. So I'm going to wrap it up there, and just to summarize and conclude, I've identified this multi-omics disease signature of fibromuscular dysplasia. So far we have found and also validated, which is important, that FMD involves these characteristic signature changes in plasma proteins, proteomics, plasma lipids, lipidomics, and fibroblast gene expression, or RNA, which is transcriptomics. We've shown that this signature likely contains causal FMD mediators. We've found that CD2AP is the top candidate for a causal role in fibromuscular dysplasia, and I think the grounds for drawing those conclusions are very strong. We've also shown that this signature holds a lot of promise, I think, for developing a test for this disease. And what are we doing next? This manuscript it's been under review at New England for a month. It may get rejected this afternoon, but I think still the fact that it went out for review is a good sign. I'm sure this is going to end up in a very prominent journal because there's nothing whatsoever known about this disease. We're also now embarking on another project that will interconnect the fibroblast data with the plasma protein data to see if we can make an even better test. We also now have a first mouse model for FMD. We're beginning to study this CD2AP in mice as well. And as I said, we're intersecting fibroblast transcriptomic with proteomic and lipidomic data to see if we can improve the test even more. So I just want to finish on a positive note. We were recently, just a couple of weeks ago, awarded the Dean's Team Science Award by the Conduits group. So this is actually the team, as me here, interacting with the clinicians, Jeff Olin and Daniela. Annette is the nurse practitioner that works with Jeff and Daniela. She does all the skin biopsies. She biopsied my mum and my wife, so that's my level of confidence in Annette. These are people in my lab involved with processing samples, microscopy, procuring clinical samples to validate CD2AP, onto the bioinformatics group here. This is all of them here. It's just an honour for me to stand before you and sort of show you that there's enormous amount of work that's really all of these people take the credit for. So that's where we're up to with fibromuscular dysplasia. I'm sure you're going to be hearing more and more about this disease as we appreciate more and more the clinical importance of us, that it's underdiagnosed, and that we have some interesting tools coming up for the very near future to help us diagnose this disease. Thanks very much.
I have like 3 questions regarding your patient that's been presented. The first thing is that what's the consensus about using the dual anti-psychotic therapy for those with the coronary dissection who did not get the PCA given concern about the propagation of the trauma? And the second question is that I think that from the cohort, from many cohorts like the Japanese saw, show that the beta blocker is kind of preventing recurrence of the SCD.
Yeah.
This patient did not get the beta blocker, was then started later.
Right.
Third question is, what's your general recommendation on the physical activity for those people?
Great question. Great. So first the question of dual antiplatelet therapy. So the question was really, can we propagate the dissection if we over-anticoagulate the patients too much? And if we don't put a stent, we really need dual antiplatelet therapy. So you're spot on. But a lot of the data about propagating dissection comes from patients with different causes of dissection. So there are other causes, like the classic one is Ehlers-Danlos syndrome. And they have a much more malignant form of dissection. They can sit in the CCU for days just propagating their dissections. This fibromuscular dysplasia associated dissection, which is overwhelmingly the most common form, seem to do very well with dual antiplatelet therapy. Because, as you can imagine, with that diffusely narrowed vessel, one of the concerns is the vessel itself can clot off. And if it clots, then we're forced to, if it's occluded, then we have to do PCI, and PCI is fraught with problems. So it's exactly the same as when people dissect their cerebral arteries, they go on a heparin drip. And that's to prevent the vessel clotting. And you're right, there'll be a small number that propagate with anticoagulation, but the majority are benefited by, in spontaneous coronary artery dissection, dual antiplatelet therapy, or in cervical dissection, heparin infusion. I have seen a patient came in, was transferred, the spontaneous coronary dissection transferred under me, that came on aspirin, ticagrelor, and a heparin drip. And they were propagating their dissection actively. So you can definitely overdo it. But aspirin and Plavix, which is not as potent as aspirin and ticagrelor, aspirin and Plavix seems to be about right. And there's no trial data, but that's what everyone does. And it seems to work fairly well. Second question about beta blockers. She was bradycardic. Up on the floor, her heart rate was down into the 40s on metoprolol. So it was actually started and then stopped. And then she disappeared back to the Dominican Republic. I've never seen her since, unfortunately. I've tried to call her in the DR, but yeah, we tried her, but she was too bradycardic. And your third question was?
Recommendation for physical activity.
Oh, physical, right. So we, after SCAD, or in FMD in particular, we do definitely advise against heavy physical exertion, strenuous weightlifting. We generally limit the amount of weight to about 10 pounds that they should be recommended to do. So, and as you know, it's true for almost any condition in medicine. The only thing worse than the primary diagnosis is if you add to the primary diagnosis inactivity, obesity, hypertension, and everything that goes with not exercising. So we do want these people to exercise, but it has to be basically non like heavy strenuous activity. And that recommendation is redoubled, obviously, if they've got aneurysms anywhere. That we really drive it home. But yes, avoidance of heavy strenuous activity is important. In spontaneous coronary artery dissection, they also unquestionably have an element of microvascular dysfunction. So they almost all of them have recurrences of chest pain, not as severe, but incredibly distressing for them. and difficult for us to manage because everyone's worried about dissecting, not dissecting, do I come to the ER, do I not? It's very problematic. But recurrent chest pain in a SCAD patient is almost the normal.
How often are these patients presenting even earlier with either refractory hypertension or early onset hypertension?
Right. So the classic early manifestation that's tragic is there's a pediatric form of fibromuscular dysplasia. So I conceptualize the whole etiology of this a bit like atherosclerosis, where most athero is garden variety, and half of us in this room have probably got it. Probably ask the males. But there are forms of atherosclerosis like familial hypercholesterolemia, familial dyslipidemias that present in the teenage or 20s. And that's a clear, autosomal dominant pattern of inheritance. And there are probably forms of fibromuscular dysplasia that do that as well. You've got one or two genes affected that we don't know what they are yet, but it prevents in a severe form. The classic pediatric forms are mesenteric ischemia, which is often fatal, which is very sad. It can present in the 20s. I think the youngest document, the first case that we presented in 1938 was a 5-year-old boy with refractory hypertension. And he actually, 5, and he actually underwent unilateral nephrectomy in 1938 and did very well after that. But it definitely can present early. But whether it's like familial dyslipidemia versus garden variety atherosclerosis, they're sort of at other ends of the spectrum.
I've seen 2 cases of therapy, both women, both young. One had a massage, the other one had a chiropractic. Is this something that triggers it? Or?
That's a great question. So as well as avoiding heavy weights, we definitely try to avoid any neck manipulations or chiropractic interventions. That's a known trigger. We've got a number of patients that Jeff has in his clinic of women that have had neck manipulations and dissected their carotids. Yeah. It's definitely a known precipitate. Uncommon precipitate, but known. And again, it's the classic thing of the postpartum state with spontaneous coronary dissection. It's probably been overplayed because we underdiagnosed a lot of spontaneous coronary dissection in the past. Now we're really seeing a lot more spontaneous coronary dissection because we recognise it. We're appreciating that the role of pregnancy has probably been overplayed. And it's probably strongly associated with those fulminant dissections where there's flaps of tissue everywhere that anyone can diagnose. But these more subtle forms like I presented are associated with pregnancy and postpartum. Thank you. Great. Thank you, everyone. So